we will see the type 1 hypersensitivity, which is IgE-mediated hypersensitivity. Okay, so IgE production is there in type 1 hypersensitivity, and that leads to the mast cell degranulation. Okay, so basically it has got two phases. First phase is the sensitization phase, and second phase is the effector phase. So what happens in sensitization phase? There is an allergen. This allergen will be processed by antigen processing cells, and it will be produced to the CD4 T cells. And these CD4 T cells will get activated, and they will differentiate into Th2 type of cells. Okay, so T helper cell type 2 cells, and these Th2 will further secrete interleukin 4 that will activate B cell, which will lead to the production of IgE. And these IgE antibodies, the Fc receptors on the mast cell, they will bind and mast cells and the basophils, and that the host will become the sensitized. So in the first phase of sensitization, there is a sensitization of the host. Once the allergen is produced, these will be processed. Antigen processing cells will be produced to the CD4. CD4 will further differentiate into Th2. Th2 will then secrete IL4. IL4 will cause B cell activation that will lead to the IgA production. And this IgA will bind with the Fc receptors on the mast cells. And the first phase is just the sensitization phase. But what happens in the effector phase when there is a re-exposure? Once the allergen binds to the IgE on the mast cells, okay, there will be cross-linking and there will be mast cell degranulation. Okay, so this mast cell degranulation is a feature of type 1 and this. And then what are the types of mediators which are released? There are primary mediators and there are secondary mediators. Primary are the histamine, serotonin, heparin, then ECFA, NCFA, and proteases. This is neutrophil chemotactic factor, and this is eosinophil chemotactic factor. Okay, so these are the factors which are released. These are the primary. Histamine will increase the permeability, vasodilation, bronchospasm. Serotonin will lead to smooth muscle contraction. Heparin will lead to anticoagulation. Then you have eosinophil chemotaxis, you have neutrophil chemotaxis, and the proteases will cause further tissue damage and the mucus secretion. Then there are secondary products which are released. These are the leukotrienes and the prostaglandins. Okay, so these leukotrienes will cause strong bronchoconstriction. Prostaglandins will lead to vasodilatation plus bronchospasm. There are platelet activating factors that will cause platelet aggregation. Remember, platelet activating factor is a secondary, while eosinophil chemotaxis and neutrophil chemotaxis. So among the cellular factors, eosinophils and neutrophils related factors are primary, while the platelet related factors are the secondary. Okay, then there is a bradykinin, which is causing pain plus permeability, and the cytokines like IL-1 and TNF alpha will lead to the systemic anaphylaxis. Okay, the vasodilatation will lead to the hypotension, increased permeability will lead to the edema, bronchospasm will lead to the dyspnea. Okay, then there is a wheal and flare reaction. So what is the sequence? There will be erythema at the site, then there is a flare, that is the surrounding redness, and then there is a wheal, that is the edema or the swelling. So what is the mechanism? It is the histamine mediated vascular changes. Again, you should remember here, this immediate wheal and flare reaction is mediated through histamine mediated vascular changes. There is erythema at the site, there is a flare, there is a wheal. Okay, now coming to the allergens. There are different types of allergen. It may be food allergens such as nuts, eggs, seafood, milk, pollens, okay, ragweed or ryegrass, then drugs, penicillin, sulfonamides, insects such as bee, wasp, others such as dust mites, mold, animal dander, etc. What are the clinical manifestations which are seen in type 1 hypersensitivity? It will be systemic manifestations such as anaphylaxis. There will be dyspnea, hypotension, there may be shock, and there may be death also. The drug of choice in this is a epinephrine, adrenaline. This is the question which is asked. Okay. Then another, there can maybe local reaction. The clinical manifestation may be systemic in form of anaphylaxis, or it may be local, such as allergic rhinitis, asthma, atopic dermatitis, food allergy, drug allergy, etc. Okay. So what are the factors influencing type 1 type of hypersensitivity? First is a genetic predisposition. Okay. Second is a dose of the allergen. If there is a low dose of the allergen, there will be persistence of the IgE. If there is a high dose, it will lead to the IgG shift. So IgE will get shifted to IgG. Okay, so there will not be, so that is the principle which is there for desensitization. You give high dose leading to the shift from IgE to IgG. If you give persistent low dose, there will be persistent IgE. But if you give high dose, that will produce from IgE, it will get shifted to IgG. Okay, then there is a Th1 versus Th2 balance. Okay, T helper cells, they are responsible for interferon gamma that inhibits the allergy, while Th2, they are responsible for IL4 and IL5 that promotes the allergy. Okay, so this is also uh, a factor which influences the type 1 hypersensitivity. What is the balance between the Th1 and the Th2? Okay. Now coming to the diagnosis. Diagnosis, it can be by skin prick test. If it is a positive, such as wheal and flare within 30 minutes, advantage is that it is a cheap. You can check multiple allergens, but there is a risk of anaphylaxis. So skin prick test is also available for the detection of the allergy, but there is a rare risk of anaphylaxis. Okay. Now uh, IgE testing. So what you can do, when you can check total IgE, you can check specific IgE against a specific allergen, or you can have some radioactive and fluorescent enzyme immunoassay, that is RAST and FEIA. Okay, this is fluorescent enzyme immunoassay. This is immunoassay. Okay, so these are the lab techniques for specific IgE. So what you can do, you can check the total IgE, but that will be only purpose for the screening. That will not be telling exactly against which antigen. What is more specific is a specific IgE. So IgE against specific allergen, so that will give you diagnostic confirmation. And allergen identification will be done by these RAST and FEIA. That is the, these are the lab techniques. Okay, so methods for measurement of the specific IgE are radioactive and the fluorescent immunoassays. Okay, so these are the assays which are performed in the lab. Specific IgE is the exact allergen identification, while total IgE, it will just give you the, there is a tendency for the allergy. Okay, now coming to the management. How, what you do if there is a allergic condition? Avoid the dust, food, drugs, pets, etc. Second is immunotherapy, that is hyposensitization or the desensitization. Third is the pharmacological, that is the most important. In anaphylaxis, you give epinephrine. Okay, that is the first line. And others are supportive, that is antihistaminics, corticosteroids, theophylline, cromolyn sodium, anti-IgE monoclonal antibodies. Okay, so these are supportive, but the main role is that of the epinephrine. Okay, so this is what is about the type 1 type of hypersensitivity.